In remember, these were patients enrolled on clinical trials, and we were not looking at the risk of higher grade ILD. We specifically looked in this pooled analysis at patients who had grade 1 ILD and were retreated. A previous analysis published by one of my co-authors, Powell, had looked at a pooled analysis of a relatively similar patient group and saw that these risk factors I mentioned earlier, older age, renal insufficiency being from Japan, or being treated in Japan, I think is what they found, seemed to increase the risk of getting pneumonitis, and therefore you would be worried about a higher grade. And then a French retrospective study also included patients who were smoking, which we haven't seen otherwise, but really the biggest risk factor was a prior diagnosis of ILD. So, unfortunately, that hasn't ever been associated with the grade of ILD that you have. And we do know that being more heavily pretreated might increase the risk. So we'd love to identify what risk factor increases your chance of having grade 4 or 5 ILD, but that has yet to be defined. There are people looking at single nucleotide polymorphisms, individual pharmacogenomic factors that might increase risk, because we have seen this curious increased risk in patients in Japan who are treated, largely of whom are Japanese. They just didn't collect that. And so that does suggest that there's a differential toxicity based on some genetic characteristics. We just don't know it yet. So instead, we're being very careful with monitoring to really maximize the safety and efficacy for these patients. We did look at this real world population, and we saw about the same incidence of ILD in a retrospective population that had been seen in the clinical trials, which I think is really encouraging. When we did see people who stayed on treatment for a very, very long period of time and no grade 5 ILD in the patients who were retreated. We also had a small group of patients who had grade 2 ILD and were retreated, which is not part of our guidelines and I think shouldn't be done in clinical practice. And we don't know what the grade 2 was due to. Maybe it was a viral infection, or the treating providers didn't think it was really drug related. But those patients were able to go on treatment. A small number had recurrent ILD, and there was one case of grade 3. But it is an interesting question, where you have these borderline cases, and that was an intercurrent illness that might have explained the findings. I think that the guidelines have already been updated to allow restarting drug with a longer period of time off drug. I think, use of steroids, I think, is increasing in popularity, low dose steroids. And also we learned from another trial that looked at T-DXd in patients with brain metastases that you do have to be aware of the fact that steroids increase the risk of an immunocompromised type of pneumonia, PJP, and we should be using PJP prophylaxis if patients stay on steroids of 20 milligrams or more for at least 2 weeks, because that's a completely preventable risk factor that can result in death. So I think we've learned a lot from these pooled analyses and from following patients. There was the large real-world analysis where we just looked at retreatment. I think we need to do more studies looking at risk factors for higher grade pneumonitis so that we can identify these patients early and potentially look at what kind of preventive strategies can be used in these patients, as well as maybe closer monitoring. And I think that's how this data is really powering our work moving forward. We're going to see data in the near future from using just 4 doses of T-DXd in the neoadjuvant setting and from DESTINY-Breast11. And then we have also looked at T-DXd in the neoadjuvant setting in the multi-center I-SPY neoadjuvant trial. So, from these trials, I think we're going to learn whether or not short exposure in patients who haven't received prior therapies and don't have the complications associated with metastatic disease, even in the post-neoadjuvant setting in HER2-positive disease in DESTINY-Breast05, whether or not we can really eliminate the risk of serious ILD in those patients. So that's another area, I think, of great interest.